Hi, everybody, whomever is out there. I'm Dr. Adam Schmitt. Thank you so much for joining us today. We'll wait a couple of minutes to let people sort of flow in here. I will introduce myself. As I said, I'm Adam Schmitt. I am a dermatologist and a fellowship-trained Mohs surgeon here at Zel. I did my undergrad at Northwestern. I did graduate school at Harvard. I did my medical school at Case Western / Cleveland Clinic in Cleveland. And I did both my residency and fellowship at Mayo Clinic before coming here. So very nice to meet you all. I will allow my co-host to introduce herself as well.
Hi, everybody. I'm going to come behind you.
All right.
Hi, everybody. I'm Alysha. I'm Lead Aesthetician here at Zel Skin Laser. And after he drops all of his knowledge on us, we're going to talk about some sunscreens and the multitude of options that you have and how to find the best one for you.
And Alysha will be monitoring the texting questions that you can write in as you think of them during the presentation. And I believe she'll either respond to them in real time, or if it's something that applies to the broader group, we'll save it for the end and then address it in a Q&A format, if that makes sense. So maybe we'll give folks just a couple of more minutes. I hope everybody is staying healthy, except for this exact moment. We are always in our N95 masks here, but wanted to make sure that everybody could see us and understand us in this moment. So that's why our masks are currently off, but we'll be right back on as soon as we're done. I probably still have some of the markings here. Okay, yeah. So these talks are also they are being recorded and will be available on our YouTube Lunch and Learn channel. If you have questions about anything and want to go back and sort of review it again, that'll be a nice resource as well. Or if you want to share with friends, family, acquaintances, neighbors, etc. So, all right, looks like it's about 4 or 5 after. We'll go ahead and get started here. So the topic of today's conversation is just kind of getting a basic understanding of skin cancer. As I said, I'm Adam Schmitt. I'm both a dermatologist and a fellowship-trained Mohs surgeon here at Zel Skin. It's important to note I have no financial disclosures whatsoever. I would like to disclose, based on feedback I got from a similar talk before, that there are no graphic images, but there are pictures of skin cancer here. So just be prepared that there are pictures of actual skin cancers here, just so you're aware. As I said, we'll kind of do an overview of skin cancer. We will identify the most common types of skin cancer and what they look like clinically, and how you might be able to find them at home, perhaps. We're going to describe how they are diagnosed in the clinic setting once you do end up coming in. We'll identify some things that can masquerade as skin cancers or be worrisome to folks who aren't familiar with them but are benign. We'll understand how you can prevent skin cancers from forming, and then describe the main treatment options that are out there. So here we go. So a little bit of background. I have a master's in epidemiology, so I want to throw out a little bit of background here. So non-melanoma skin cancers are the most common types of cancers there are. And most of these are not tracked explicitly because they are so common, but we estimate that they're more common than all other types of cancer combined. There are an estimated 5.4 million cases per year in the United States alone. The vast majority of them are basal cell carcinoma. It's the most common type of cancer. And then squamous cell carcinoma, approximately 20%. And then other types of skin cancer make up a small number of all the types of skin cancer that are out there. Rates are on the rise, in particular among women under the age of 40. That seems to be a group that's rising a little bit faster than everybody else. So like I said, basal cell carcinoma, the most common type. These are all depictions of what look to be nodular basal cell carcinomas. These arise from UV damage, most commonly from the sun, leading to a specific mutation in the skin that a lot of basal cell carcinomas share, and that accumulates over time and creates these skin cancers. Risk factors include having fair skin, smoking, which is a risk factor for almost everything, having your immune system suppressed, either from a disease or from medications you're taking, and then a few very rare genetic disorders. Metastases are very rare for this type of skin cancer, but they are locally very destructive. Superficial basal cells are only located in the epidermis, which is the very top layer of the skin, as you'll see in that cartoon on the right hand of the screen, paper thin layer of the skin. So those don't have roots to them, but they spread out laterally. Nodular basal cell carcinoma, as I mentioned, is the most common type. The nose is the most common location to get it. Over 80% are on the head and neck, though, in general. And these are, we describe them as pink pearly papules. They have a very shiny appearance to them, very prominent blood vessels. And then they grow. They just continue to grow. They don't just stay at one size. And they oftentimes will bleed on their own. You didn't pick at it. You didn't do anything to it. You just dried your face off with a towel and all of a sudden it starts bleeding. So that's a very telltale sign of a basal cell carcinoma. Another subtype is these infiltrative kinds. They look like a scar, actually, and that's why they can be kind of tricky. And they are oftentimes deeper and wider than they look to the naked eye. Next, we'll talk about actinic keratoses. We consider these precancerous. They're these bright pink patches on macules or patches on the skin that have this really thick scale that's really stuck to it. They have the potential to turn into squamous cell carcinoma. Sometimes they go away on their own. Sometimes they stick around for a long time, but they can turn into squamous cell carcinoma. If they have any symptoms, it's usually itchiness. And people know, oh, I tried putting lotion or cream on this for a long time and nothing changed. So as I said, you have this sun damage. It can turn into these actinic keratoses, which are precancerous, and then in situ squamous cell carcinoma, so just in the epidermis, and then eventually it could become an invasive skin cancer. Oftentimes we'll treat these on the spot with liquid nitrogen. Sometimes you can kind of scrape them off, especially if they're really scaly. If you have a lot of them, we'll talk about field treatment, which is either with a cream, with a chemical peel, or with a special blue light treatment. And that's for folks where instead of pulling up individual weeds, it's better to spread weed killer everywhere and kind of clear the field, so to speak. This is an example of folks who had the Effudex treatment. You can see a very profound reaction, but then when they heal, the skin heals very smoothly and without all those precancer changes there. So squamous cell carcinoma is what these precancers can turn into. Here are some examples. Again, oftentimes head and neck. These are from years and years and years of sun exposure. So we see these almost exclusively in folks over the age of 50. Same type of risk factors as with basal cell carcinoma. They can occur in areas with HPV exposure. Again, it can be very superficial, just in the epidermis, or it can be invasive, going down into the skin. These do have the potential to spread to other parts of the body. A lot of my research and folks I saw had the more aggressive types of squamous cell carcinoma, so I have a very healthy respect for these. The vast majority, though, are easily treated in clinic. Wanted to touch on melanoma. My colleague, Dr. Vance, did a full talk on melanoma, but certainly it's important to talk about it here, obviously, as well. These are moles that have gone bad. This can be from both high-intensity short bursts of UV exposure, for example, tanning beds, which are these very, very short bursts of high-intensity UV rays. Between men and women, it's the 5th most common type of cancer, period. High-risk individuals, same type of risk factors. Fair skin males, especially older males, UV or tanning exposure, having your immune system suppressed, having lots and lots of moles. That's the word nevi you see there, multiple nevi. And then a personal or family history of melanoma. There's certainly a genetic component to it as well. And these come in several different flavors. They can be in situ, so again, just in the top superficial layer, spreading out superficially. They can have more of a nodular feel or look to them under the microscope. They can show up on the hands and feet. That's the acral type. Amelanotic is what keeps dermatologists up at night. Those are the ones that are not dark brown or black or anything. They just look like a pink bump. And then subungual, so under the nails. Here are a few examples. Amelanotic on the left here. That's a melanoma, but doesn't have that, dark black appearance that we all associate with melanoma. This is one under the nail, multiple bands of different colors on the nail itself, and then one that's gotten progressed quite a bit under the nail as well. So things to look for melanoma, we talk about the A, B, C, D, E's of melanoma. This was just a nice example from La Roche-Posay, but we talk about these in clinic all the time. You're looking for moles that are asymmetric, so one half completely different than the other. Strange borders, so instead of a nice round border, they have these irregular jagged edges. Instead of being just one or maybe two colors, you see several colors: light brown, dark brown, black, bluish, white, red, multiple colors throughout one lesion. Big size, so greater than the head of a pencil eraser, and then evolving or changing over time. So anything on the skin that's changing, becoming symptomatic, getting those different colors or shapes, those are worthwhile to get checked out by your physician. Here was a patient of mine, very good example of a melanoma, and you can see jagged edges, multiple colors, asymmetric, kind of has all the telltale signs there. These mostly are new moles. They can certainly arise in older ones, but the majority of melanomas are actually new spots that show up. So keep an eye out for those. They can appear in non-sun exposed areas. And then when we take samples of them, we're looking for depth, and that really determines how we treat it and what the outcomes are likely to be. Common management, most of them can be excised or cut out. Certainly some of them are amenable to Mohs surgery, and we'll get to that later. And then if they're more advanced or there are reasons not to do surgery, then there are medical treatments like immunotherapy, chemotherapy, and radiation. So when you come into the office, what to expect? We want to take a history, both a personal history and then a family history as well. We want to do an exam, ideally by somebody who is used to looking at skin. So dermatologists are trained specifically to be looking at skin all day long. And after doing that for years and years, you get a good sense of patterns and things that shouldn't be there. Certainly there is no crystal ball, but we do our best to really train our eyes to look for abnormalities. You can have photos done, which are really nice for people who have a lot of moles to sort of track where things are and if things are changing. There's dermoscopy, which I'll talk about soon, and then taking a biopsy to really get an answer. Dermoscopy are these little, they're basically a magnifying lens that has an LED light on it, and certain skin growths have certain patterns to them. Again, it's not always a slam dunk, but it really gives us a lot more information for us to decide, do we need to take this off? Can we watch it? Or is it completely reassuring? If we end up advising a biopsy to really define whether there's a skin cancer there or not, there are two main methods. One is a shave biopsy, where we numb up the skin first and then take a blade and take off whatever the growth is, send it to the lab and have it looked at under the microscope. And then a punch biopsy, which is really sort of taking a plug of skin out. And there are reasons to do both and situations to do both. Sometimes something is so big that we have to do another type of biopsy called an excisional biopsy, where we cut around the whole thing and take it out and put a few stitches in. So common benign skin lesions, I'll go through these fairly quickly, but I wanted to put in things that people ask a lot about, or they come in and worry that it's a skin cancer, and it may not be. So seborrheic keratosis is extremely common. I call them wisdom spots. They're overgrowth of the top layer of the skin, very common on the back, but it can go on the face, scalp, chest, anywhere, but back is the most common place. And these patients describe them as their barnacles or their rough spots, but they're usually these rough brown spots. Solar lentigines, these are sunspots. These are your body's response to accumulation of sun exposure and trying to protect itself by having these more brown spots. Often in sun exposed areas, back of the hands, very common, neck, face, areas with high amounts of sun exposure. Milia, these are little cysts underneath the surface of the skin. To get these out, oftentimes we'll make a nick in the skin and kind of express them. There are some medications as well that can help turn over the top layer of the skin to get them out a little bit faster. Solar purpura, these are bruises basically, but they tend to occur in areas that have had a lot of sun exposure because the sun breaks down the collagen and the elastin in the skin, making you more susceptible to bruising in these areas. But hands and forearms are very common. Sebaceous hyperplasia, these are dilated oil glands, very, very common on the central face in particular. But sometimes they look like basal cell carcinomas, and so we'll do a biopsy worried about a basal cell carcinoma. It comes back as a dilated oil gland. Epidermal cysts are these collections of keratin underneath the surface of the skin, very, very common as well. Pilar cysts are another type of cyst, most commonly on the scalp. And then angiofibromas or fibrous papules are most common on the nose. Again, if we do end up biopsying these, it's because we're typically looking for a basal cell carcinoma. And then a dermatofibroma, most common on the legs or the arms. These are almost like a little bit of scar tissue, often from a very minor injury like nicking your skin from shaving or a bug bite or something like that. And then cherry angioma is extraordinarily common, most common on the stomach and the chest, and these are these dilated blood vessels, bright red or pink spots. So we'll talk a little bit about protection and prevention, and Alysha will touch on it more later, but we have some very basic recommendations. If you're going to use sunscreen, which obviously we recommend at least SPF 30 or higher. You want it to be broad spectrum, so it covers both UVA and UVBs, both of which contribute to skin cancer. And then we want you to reapply it, and that's often the key. You know, doesn't matter what type of sunscreen you get, you need to reapply it every couple of hours because the efficacy does wear off, even if it is water resistant. And the physical blockers, there are two main categories of sunscreens: the physical blockers and the chemical sunscreens. Physical blockers literally block the UV and the visible light from entering your skin, and those are zinc oxide and titanium oxide as the active ingredients. Those are typically less irritating, but they're usually in a cream form. The chemical sunscreens, which are more likely to be a spray, they absorb the light, but then they sort of transform the wavelength, and so it's not a cancer-forming exposure anymore. And those are more often likely to be a spray. And then the other important components of sun protection are physical blockers like shade, umbrellas, wearing the sunglasses like I have there, and then UV protective clothing. This is from a local company, but a lot of companies are making these UPF clothes now. So instead of SPF, it's UPF. And these are clothes that basically act like SPF 50 sunscreen, but you're not having to reapply sunscreen all the time. And here's just some examples of clothes that have that UPF protective factor built into them, which is really nice. And just a nice illustration, again, this is from the Coolie Bar site, just because they had a very nice illustration of this. But your average t-shirt, a white cotton t-shirt, really doesn't have a lot of sun protective factor, and especially if it gets wet. The clothes that have the UPF 50 plus are blocking 98% of a broad spectrum of UV rays. It doesn't matter if they're wet or not. So there is a big difference, even if you are wearing a long sleeve shirt or regular shirt, it's not protecting as much as a high SPF sunscreen would be, or a UPF clothing. So we'll talk about treatment here. There are several different non-surgical options. A lot of these superficial skin cancers can be treated without invasive techniques. So you can scrape them and burn them. You can scrape them and freeze them. Some of the more superficial ones you can sort of treat with a chemical peel, topical chemotherapy, cryotherapy, which is the freezing treatment. If folks aren't a good candidate for surgery, sometimes we'll go down the radiation route. And then if things have gotten progressed, then we can talk about chemotherapy or immunotherapy. That's a minority of patients. Most are amenable to some type of surgical treatment, and you can do that with a local excision, either a narrow or a broader excision, excision with frozen sections sort of in real time, or Mohs surgery, which a lot of people will have questions about. I wanted to dedicate a small section to it. So as I mentioned, both myself and my colleague, Dr. Vance, are fellowship trained Mohs surgeons, meaning that in addition to our dermatology residency, we spend an additional year getting specialized training in how to perform this specific type of surgery and to do it correctly. People will often ask, is it an acronym or is it a name? And it's actually named after Dr. Frederick Mohs, who developed the initial technique back in the 1930s, but obviously has been refined multiple times over the past 80, 90 years. So the basic tenet of it is, instead of doing what's called bread loafing sections, where you're just looking at a few slices of it, we process the tissue in such a way that we're able to look at the whole periphery of it, as you see on the bottom here. So in the top, just looking at a few slices, you might miss that at one edge, skin cancer went to the edge, whereas with Mohs, we're able to look at the whole periphery and see that one of the edges was positive, and then go back and take a little bit more skin only in that spot. This is another cartoon sort of illustration of that. Mohs being on the left, showing you that we're able to look at 100% of the edges and see that under the skin, there's a positive margin here, and we need to take a little bit more there to make sure that we get all the skin cancer. Whereas if you take the same tumor and just excise it, you might miss, in this section, it looks like the edges are clear, but you might miss that there's actually still skin cancer left over there. This is a nice illustration in one of our dermatology textbooks, but performed by some of my colleagues at Mayo. So this is a basal cell carcinoma on the nose. We'll scrape it, take a very narrow margin, try to hug in the edges, mark the skin so that we know on a map exactly what we're looking at. The tissue is inked, processed. We looked at it under the microscope, typically within about a 45-minute, half-hour to 45-minute period. It was noted that there was skin cancer just at this one spot. So you go back, you take a little bit more skin only where it was positive, like was done here, put it on the map again, look at it under the microscope, see that there's no residual skin cancer, and then most surgeons are also trained in how to do the reconstruction or to fix the holes that are made after the skin cancer is removed. This was with something called a Burroughs advancement flap. So advantages, you get confirmation of tumor removal with the highest cure rates in real time, preserved tissue. We perform it under local anesthesia. It does require a special lab and folks who are trained especially to do it. And it's costly versus standard techniques, not costly versus going to an operating room. So that's why it's reserved for only indicated situations. And we have appropriate use criteria to tell whether treating specific cancers is appropriate to do using the Mohs technique. This very quickly shows from a very nice paper from the Mayo Clinic Proceedings from a couple of years ago, the cure rates of Mohs surgery versus wide local excision, quite a bit higher for Mohs surgery for all these types of skin cancer, including the more rare skin cancers. And that advantage becomes even more apparent if a skin cancer comes back or is recurrent. The cure rates are far better doing the Mohs surgery. And then again, briefly, as I mentioned, Dr. Vance and I both did a Mohs fellowship, accredited since 2003. There are 76 programs out there, and you have to do a high number of cases and complex cases, and then it will be required to do this as of fall 2021 if you want to be labeled as a Mohs surgeon. So I just wanted to thank Dr. Barbosa, one of my colleagues from Mayo, who had put together a lot of these initial slides. My wife, who helped review, Dr. Jennifer Schmitt, and then references here as well. And thank you for coming today and for paying attention. And we will start by having Alysha just talk about some of her ideas and some products here, and then we'll open it up to question and answer here.
So when he was talking about protection and prevention, it really is like diet and exercise. They go hand in hand. By far the most common and most effective prevention is a vitamin C in coordination with an SPF, but we'll get to that. So the two, I think, most popular ones, or ones I'm going to talk about today, are one is the Floritin from SkinCeuticals. This is a really great starter. It's meant for people with kind of normal skin. If you have dry skin, you might want to look elsewhere, the next one that I'm going to talk about. But it's L-ascorbic acid. So what this does is it's basically a security guard for your healthy cells. It will protect your healthy cell and try to fight off free radicals, which is sun damage, pollution, smoke, blue light from screens or devices. You use it in the daytime, about 3 or 4 drops. What I recommend is putting it on the top of your hand and then patting it in, but then spreading along the top of your hands, the rest of it. Because when we're driving, we get that exposure on our hands and damage on our hands that will protect our hands from that exposure. Another one of my favorites, because it's multitasking, is the Pro Heal Serum from IS Clinical. Now, what this does is anti-inflammatory as well. So for those of you who are a little bit more prone to pigmentation from hormones, or if you've had a baby or anything, this will help eliminate some of the heat that's held in the skin and help with the anti-inflammation as well as protecting your healthy cells. Now for sunscreens, I'm sure all of you know there's a lot on the market, and it's kind of hard to determine which one is best for you. There are definitely some that are meant for face and some that are meant for body. And usually what that is our face is significantly more sensitive than the skin on our body. So we do want to make sure we are using two separate for face and body. A lot of the times you are going to find a long list of ingredients on the back. What he had said, and our most effective is a zinc oxide. Some of our most protective and popular sunscreens are the Elta MD line. They have so many different formulations. There's something for everybody. They come in tinted and non-tinted versions. That does not change the efficaciousness of the products. It's just your personal preference if you want something that gives you a cosmetic finish or not. They are broad spectrum, so it's UVA, UVB. Some of their new formulations have the blue light block 2, but they have zinc and titanium, what they are. And sunscreens have come a long way. When we think of zinc, we think of the white color. This will absorb very quickly and will not leave that funny white finish. So if you are a cosmetic wearer, everything will go on these smoothly. And they do make a wide variety of face and body, and they are water resistant for up to 40 or 80 minutes. So if you have questions, you can feel free to call us, email us, send them in, and we can help you find the right one. Another one that we have is people will ask about mineral sunscreens. Basically, it's zinc and titanium, but then there's a little bit of octinoxate in there as well. So it's just a different form of protection. One of our favorite is the IntelliShade True Physical. The reason we like it is this one has a little bit more of a cosmetic finish, but it's for people who have more oily skin and want a good thick sunscreen that is also going to hydrate and has some peptides in it as well. UVA, UVB, water resistant. This is a great multitasking if you just want to put something on in the morning, not worry about anything else, and go on about your day. They make 3 different formulations. There's an original, there's a matte, and there's a True Physical. Again, you can send a message to figure out which one is going to be better for you. And then another one I wanted to talk about was the SkinCeuticals Physical Fusion. This is another one. It's zinc and titanium, but it's an SPF 50. It's broad spectrum. It's a fluid. So it's not a cream like some of the other ones. It penetrates very quickly. It's very light. This is another mineral shield as well. A lot of people will ask, if I have SPF in my cosmetics, that's fine. A lot of the mineral cosmetics also have some of the SPF mineral properties to it. Cosmetic SPF is never going to be enough for you. You need something that has the broad spectrum. This is really great in conjunction with any of your mineral cosmetics that will work really, really well together. Again, there's so many different options out there for you, so we here can help try to figure out the best one for you. Just send us an email, or there is one question that I'll go ahead and answer. Oh, best way to protect lips from sun exposure. So Elta MD also does make a lip SPF. It is like a lip balm, and it has a 21% SPF, I believe. It is water resistant, UVA, UVB. We also carry a line called Color Science that is, it's a mineral, or it's a cosmetic sunscreen line. They make a lot of different products that are multitasking, that will cover redness, which we use a lot in post-procedure, that will cover up hormonal pigmentation differences, but also has that UVA, UVB. They make what's called a lip shine, which is an SPF 35. It comes in a few different tints or just completely clear for those of you who don't want a tint. And that will stay on for a few hours. So there are a lot of good lip SPFs out there as well. And I encourage using a lip product, because if you put this on, it's going to taste a little funny. We don't want to do that. Let's see, there's one more question. Favorites for body that won't rub off on clothing. So with that, you probably want to go the non-tinted route. And a lot of people, it's boat season here. So we want to make sure we don't have anything that rubs off on our boats or the seats on our boats. So the UV Sport from Elta MD is probably our most popular for people who are wanting a body sunscreen and are outside and are active and don't want a lot of transfer. They also make a spray, an aero spray. You want to allow that to dry about 4 to 5 minutes before you put your clothes on to make sure it's dry. But those are the two most effective that will not transfer onto your clothing. Again, it's the Elta MD Sport and the Elta MD Aero, A-E-R-O. When we have both of those in stock at Edina, our Edina location, you can call and place order over the phone. We can ship them to you, or we are open for purchases to come in. If you want to look and kind of weigh your options, we have that too. All right, I'm going to turn it back to Dr. Schmitt.
Excellent questions there, and especially on the lips. Those are a high-risk location for making skin cancers, in particular squamous cell carcinoma. So, great question. So, unless there are any more questions, which I can't see. In summary, basically, if you're noticing something that's growing, continues to grow, bleeds on its own, is becoming painful or tender, or you notice a mole that's changing in size, shape, or color, those are all worthwhile things to come in and get checked out. And then we can always go from there in terms of what we think it looks like, whether a biopsy is necessary, and then treatment based on that. So if there are no further questions, I'll sign off here. Thank you all again for joining. It's been a pleasure. Be well and stay healthy. Bye-bye.